Good morning, everybody. It's a pleasure to be here. I'm Jonathan Parker. I'm a dentist and practice in Minneapolis, Minnesota, and I'm on the faculty associate position at Tufts University in Boston in dental sleep medicine. I've been practicing dental sleep medicine and working with the sleep medicine providers in the Twin Cities for 30 years. And so I'm grateful to be here with you today to share some information on oral appliance therapy. I want to thank Dr. Muna Irfan for the invitation to present the program today. As many of you know, she's the medical director of sleep services at the VA in Minneapolis and the program director of the Sleep Medicine Fellowship at Hennepin Healthcare here in Minneapolis, and also the assistant professor in neurology at the University of Minnesota. And I'm really grateful to have the opportunity to collaborate with her and to learn from her. And so it's really nice for me to be here and share some of this information with you today. So you can answer in the chat, but how many of you currently work with a dentist in managing sleep apnea patients? Just raise your hand, put a yes, whatever. Oh, they're coming in. So a few of you. I guess my next question is, how many of you actually know what a dentist does in managing sleep apnea patients? And that's really what I want to focus on today. We only have about an hour together, so there's a lot of information, and I've tried to really pare it down to something that will be helpful for you. So as far as conflicts of interest, I'm co-founder of the Sleep Performance Institute. I'm chief dental and science officer at Gem Health, but neither of these will have any connection to this presentation. So what I really wanted to help as far as learning objectives for you today is to give you indications for when oral appliances are appropriate, talk a little bit about the protocol for use of oral appliances, how dentists match patient characteristics with the features of the appliance, and talk a little bit about some of the common side effects of oral appliance therapy, and a lot more. But those are the things that I'm hoping that you'll take away from this. So we're all aware of the most common treatments for sleep apnea, both surgical and non-surgical, and positional therapy and weight loss, oral appliances. CPAP obviously is the most effective and the gold standard for managing sleep apnea. And then there are the airway surgeries that are available as well. In Minnesota, interestingly, medical cannabis obstructive sleep apnea is a qualifying condition for medical cannabis, which I don't think it is in many other parts of the country, but an interesting fact. The unique piece here is that everybody seems to have an opinion on what therapy would work best, what a patient would tolerate best or be most interested in. And what I want to do is just talk a bit and focus a little bit today on oral appliances and how it fits into these, and try and separate opinion from fact. Actually, as you look at this, there are people who have a strong opinion about whether your toilet paper should roll over or under. And there is data on this, which I was surprised to find, but 80% of the people set up their toilet paper with the roll going over as opposed to under. I know that's a really important fact for you to hear today. So moving on to more important topics. So what are the indications for oral appliance therapy based on the data that's out there? So oral appliances are an excellent option for people who have primary or heavy snoring without any apnea or without obstructive sleep apnea present. So for patients who have an AHI less than 5, about 85% would say, or would in some of the studies that are out there, would say that their treatment was successful in managing their snoring. Oral appliances are highly effective for mild to moderate apnea and certain cases of severe apnea. Just to give you some statistics in my practice, and my practice is limited to dental sleep medicine, so I've been doing this full time for a long, long time. And I would say 49% of the patients that come to my office have moderate to severe apnea. So we see a lot of people in this situation after they've tried CPAP. It's indicated in patients who don't tolerate CPAP, who have poor efficacy of upper airway surgery, patients who use their CPAP at home but are not able to take it for travel, or they're going to remote areas where they don't have electricity. Then oral appliance therapy may be an option for them to use during travel. And we're seeing a lot more patients where we're using appliances in combination with PAP therapy, or after surgery if it isn't effective enough, or with positional therapy. And we'll talk a little bit about that as well. There are basically two functional classifications of oral appliances. There are the mandibular advancement devices, which I'm going to talk about most because we have the most research data on these devices. Tongue retaining devices are available, but they're becoming less and less available, and they're not used as often as they did. So I'm not going to talk too much about those. So the question comes up, how do these mandibular advancement devices work? Well, if you look at the data, it essentially holds the jaw slightly forward, which stabilizes the mandible, the tongue, and the hyoid bone. It increases airway size in a lateral dimension, which doesn't, it makes sense from a physiologic standpoint, but it may not make sense initially if you're thinking about it. When you move the jaw forward, you would expect the airway to open more anterior posteriorly, but it actually opens more laterally, and I'll show you some imaging in a study in a few minutes on that. And it increases baseline genioglossus muscle activity. It tightens it up a little bit so it doesn't fall back into the airway as easily. So here's a study that was done in Australia where they did imaging of patients without a mandibular advancement splint and with a mandibular advancement splint in the machine, in the imaging machine. And what they found is that the airway opened more in a lateral dimension, and it opened most in the velopharynx, the junction of the soft palate and base of tongue. So that's been duplicated by a number of other sources as well. So I want to show you, I'm going to show you a video right now of a patient who came into the scanner with, this is now, I'm going to move my cursor. Study. And I don't know if you can hear the audio, but I'm going to talk over it a little bit. Inspiration. We watched a pulse oximetry. At this point, they're making cuts through 95% down through the airway, and we haven't gotten to the images are 8 millimeters. We haven't gotten to the nasopharyngeal or oropharyngeal airway yet, and but it will come in a minute here as they're making the cuts down through the skull. All right, so my cursor is on the airway, and this is an apnea patient, and you're going to see this is fast scanning. So you see the airway close almost completely. And you can see this is happening over time, but it's a fast scan, so it's happening over minutes and not seconds. And you can see the continued airway closure. Now they're going to place a mandibular advancement device in the patient. And here you see, again, I've left the cursor on the airway, and you can see that the airway is maintaining its shape. The airway is maintained. And it is opened more in a lateral dimension than in an anterior posterior dimension. So that's what I wanted you to see with this imaging on how oral appliances work. And that's how mandibular advancement devices work. So they hold the jaw forward and it opens the airway in a lateral dimension and allows easier breathing. The tongue retaining devices, it's basically a compartment that holds the tongue forward, and it actively opens up the retroglossal space, and it tends to counteract tongue muscle activity. The challenge with these is that the tongue will tongue muscle activity will shift during the night so that the tongue may come out of the compartment in the device, and the patient, it will wake up the patient, and they have to then reset the tongue in the compartment, and this goes on off and on all night. So what I want to share with you today is that there is a ton of science and research around oral appliance therapy now. But it really is a blending of art and science, like so much of medicine is. And so experience has a lot to do with managing these patients and having success. So I want to go through briefly and just give you some highlights on the research. These are typically the questions that are asked of me when I'm lecturing around the country. So people will ask, well, what type of appliance is most successful? Does more jaw advancement in the appliance lead to more success? In other words, is there a dose effect? What's the efficacy of these devices? What patient characteristics lead to increased success and decreased success? How does success with oral appliances compare with CPAP? What's the compliance rate with oral appliances? And do oral appliances improve health outcomes? So this is all important information that I think all of us want to know when looking at a treatment other than CPAP. So let's talk about the first question, which is what type of appliance is most successful? So the top device is a non-custom appliance. It's over the counter. You can buy it online, and you boil it and put it in and move your jaw forward to close into it, compared to a custom-made device that is non-adjustable, which is the middle picture, and an adjustable oral appliance or mandibular advancement device, which has screw mechanisms on the side to advance it slowly, advance the jaw position slowly to improve success. So the answer to the question is a custom-made dual block, upper and lower, in other words, adjustable mandibular advancement device are much more successful than an over-the-counter device, and there are a number of studies on that. And they're more successful than a fixed device that is not adjustable. You can't adjust the jaw position. The second question is, does more advancement lead to more success? In other words, is there a dose effect? And the answer is yes. More advancement leads to more successful outcomes because as we advance the jaw, it tends to open the airway more, and we tend to improve outcomes. Successful advancement is typically more than 50% of maximum jaw movement. And for most people, 50 to 60% of jaw movement is very comfortable. As a matter of fact, they don't feel like their jaw is forward very much at all. Yet this can lead to significant success. The beauty of an adjustable mandibular advancement device is that during the course of treatment, if the patient's symptoms are not improved enough, or on testing objectively they're not improved enough, we can advance the jaw slowly to the sweet spot, to the jaw position that will work most effectively. If you look at all the data on efficacy of mandibular advancement devices, for snoring, I told you it's somewhere around 85 to 90%. Success in mild sleep apnea, and we'll stick with the current guidelines, and in the field right now, they're focusing most on AHI, although I think that's shifting. But an AHI of 5 to 15 or mild sleep apnea, there's probably 70 to 80% success based on the research data. 55 to 65% success in moderate sleep apnea, AHI of 15 to 30. And in patients with severe apnea, we still have 40 to 60% success. And pretty much all or most of these patients have tried CPAP, same with moderate sleep apnea. And so we are increasing successful outcomes in those patients. It's just not at as high a rate as we do in milder patients. What's the effect of mandibular advancement devices on health outcome? Well, if you look at the data, there are probably now 10 studies that were done looking at mandibular advancement devices and the effects on blood pressure. And the effects on systolic and diastolic blood pressure were about the same magnitude as with CPAP as far as improvement. Mandibular advancement devices appear to reduce cardiovascular morbidity, although there are limited studies on this, so we can't state that with definitively. And mandibular advancement devices showed significant reduction in C-reactive protein, interleukin 1/6, and tumor necrosis factor. Again, this is 1 or 2 studies, so we can't really definitively say that, but there's a trend in that direction. So bottom line is we are seeing improvement in cardiovascular health with mandibular advancement devices. Comparing mandibular advancement devices and CPAP as far as treatment outcomes are concerned. Clearly, CPAP is more effective in reducing AHI and improving oxygen saturation levels. So it is the most effective, obviously, because we can modify air pressure to maintain airway patency. Mandibular advancement devices have a much higher compliance and patient acceptance. So, I would say efficacy with CPAP is higher, effectiveness with an oral appliance is higher. So that's the challenge that we run into in trying to manage patients. Reduction in cardiovascular markers is similar. What about CPAP versus oral appliances or mandibular advancement devices in symptom outcomes, how people are feeling and their function? Well, the outcomes are basically similar, equivalent for daytime sleepiness, quality of life, cognitive performance, and simulated driving. So symptomatically, patients tend to do very well with either. What about side effects? So that kind of gives you a brief overview of the research, and because of the limited time that I have today, I wish I could go into more detail, but hopefully that gives you sort of an answer to some of those questions. And digging into the literature, I think you'll find a lot more support for what I was talking about. Potential side effects with mandibular advancement devices. Initially, people may find, and it's a small percentage who have excessive salivation or a dry mouth, but it can happen. So I always talk to patients about that. But that is not really a significant issue. Soreness in the teeth or jaw, generally that will occur in the first few weeks of use, if it does. And 90% of patients have no issues with either of them. So it's a small percentage that do, and we will tell patients, if you have any soreness in your teeth or jaw, because you shouldn't, that shouldn't happen. If it does, then we can modify the appliance and resolve those issues. So I think that's the take-home message, is that a qualified dental provider should be able to adjust the appliance so it's comfortable on the teeth and the jaw is comfortable. But the patient may find that they have some of that happening over the first few weeks, and they need to call and come in so that we can take care of it. What we know is that when they take the appliance out in the morning, their bite is going to feel funny. So we will make them, you can see this AM aligner, we will make them a little device that's set up in their normal bite. And when they take their appliance out in the morning, they will use this morning positioner while they're shaving, in the shower, getting dressed, doing other things. They have this in their mouth and they're closing into it periodically, and it guides their jaw back into position so the bite remains stable. So we inform the patient that their bite's going to feel a little funny in the morning, but it'll go back to normal within 15, 20 minutes working with this morning positioner. Long term, as I said, probably 10% of the patients may have an episode of jaw pain, but it's kind of like spraining an ankle. It isn't going, I've never had a patient who quit wearing the appliance who had ongoing pain. So it will go away. It's like a sprain. But we need to balance the appliance to the way the patient's jaw functions. And so that's where the patient comes in. We fine tune the appliance and the jaw pain should resolve. TMJ issues, and the TMJ just refers to the temporal mandibular joint or jaw joint. And the research data shows that the impact of oral appliances on the TMJs long-term is minimal. And so there really isn't any data that shows that there's any long-term implications of using these appliances. Bite changes can occur over time as patients use these devices for 7-8 hours at night. Using that morning positioning program, like I told you, to get the jaw back into position reduces the chance that they'll have bite changes over time. Most people who have bite changes have no pain, no functional problems. They can chew and talk and do whatever they need to do. But the dentist, is monitoring that. And so they don't have real symptoms related to it, but we want to keep the bites in place and solid long-term for patients as best we can. Compliance with mandibular advancement devices. The studies that were done using compliance monitors as opposed to questionnaires, compliance was at 82% and the mean rate of use was 6.7 hours per night. I'm showing two studies that came out quite a while ago, and there's a new study that came out that supports this as well. So compliance rates are high with mandibular advancement devices, at least within the first year. I think it starts to decrease gradually over time, as many medical therapies do. So the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine have developed practice parameters around use of oral appliance therapy for sleep apnea. The last paper came out with practice parameters in 2015. I expect there will be there is so much research being done on oral appliances in the last 10 years. And this paper came out in 2015, so that's 7 years old. But based on the data that they had at that time, here are the recommendations for oral appliance use. So sleep physicians should prescribe oral appliances rather than no therapy for primary snoring. And again, the reason for this is that even though it may not have huge health consequences, snoring is still a symptom that is significantly bothersome for patients and is usually part of their chief complaint. So managing it is important to help manage their chief complaint. And so that was number one. Number two, a qualified dentist should use a custom titratable appliance over a non-custom over-the-counter appliance. And the data is clear that over-the-counter appliances are not effective and they're not tolerated very well because they're so bulky and they tend to be loose on the teeth. So a custom titratable oral appliance is the treatment of choice and should be recommended. Number three, oral appliances should be prescribed for sleep apnea patients who are intolerant of CPAP or prefer an alternate. So in a patient who can't tolerate CPAP, oral appliance therapy is a second-line treatment. Or if somebody refuses CPAP, then an oral appliance may be considered a first-line treatment. So in those situations, when they come to my office, I spend a lot of time trying to encourage them. If they have moderate to severe apnea, I encourage them to try CPAP first, at least a trial period, before they move on to oral appliance therapy. For mild apnea, I think oral appliances are an excellent first-line treatment. All right, the third recommendation by the academies is we suggest that qualified dentists provide oversight rather than no follow-up to survey for dental-related side effects, which is absolutely critical. And so the dentist, we follow patients once their symptoms are managed and they're objectively improved on sleep testing with their appliance. then we put them on routine yearly follow-ups. So we're monitoring for side effects, and we're monitoring the appliance and making sure symptoms are being managed. Sleep physicians, this is number 5. Sleep physicians should conduct follow-up sleep testing to improve or confirm treatment efficacy. So we refer all of our patients back to the sleep medicine provider for follow-up testing or to determine if follow-up testing is necessary. Number 6, sleep physicians and qualified dentists should instruct patients to return for periodic office visits, which is what I was just mentioning. In our office, we see them on a yearly basis. So those are the recommendations of the Academy on how we should be using oral appliance therapy. Let me just go through briefly and talk to you about what a dental evaluation, dental sleep medicine evaluation looks like for patients. When I ask my sleep medicine providers that I've been working with for decades, to come into my office and just see what we do, they had no idea that we go through this much time and evaluation with patients, and they really didn't understand what we do except give them an appliance, which is a part of what we do, but it's not necessarily a major part of what we do. Might be the most important part. So the protocol really looks like this. So if the patient will go in for an evaluation with the sleep medicine provider, and generally sleep testing has been completed and a diagnosis is given. Then the patient is referred to our office or to the dental sleep medicine provider. We'll go through a complete history and examination. We'll do impressions and a measurement for an appliance. Once the patient says they want to move forward, we place the device. We follow them routinely until they are gradually advancing the jaw position until their symptoms are resolved. And if they have moderate to severe apnea, we may do some initial testing just to confirm that we're in the ballpark of resolving the problem, and then we'll send them back to the sleep medicine provider to do either a home sleep test, which is being done most now, or we've done research on titrating oral appliances in the sleep lab, and our study, it was a study that we did in our center and published in 2009 that showed that there was a 25% increase in success if we titrate the patient in the sleep center with their oral appliance. And that can be done. There's a protocol to do that, and I'll share that with you. And then we put them on 6-month follow-up and then yearly thereafter. So patient interview is somewhat similar to what you're going to do. We assess and ask the patient and their sleep partner about frequency, loudness, and the effect of snoring on others. We talk about and ask about daytime drowsiness and the effect on their daily activities, cognitive impact, and driving. And again, this is just a brief summary, but we talk about quality of sleep, and we want to know what position they typically sleep in, because that will impact the severity of their apnea. And then we ask about changes in weight, hours of sleep, caffeine, exercise. If they have a history of jaw problems, nasal congestion, smoking. It's a comprehensive patient history. We'll go through and we will generally have the patient's sleep testing and recommendation from the sleep medicine provider about treatment prior to them getting to our office. Sometimes we have to call when they get there if we haven't received it yet. But we work very closely with the sleep medicine providers in our area to collaborate and coordinate care. And then we get an update on what previous treatments they've had and how it's gone. Then we'll go through a dental evaluation. So I was told by a marketing person once, never show pictures of the oral cavity because it freaks people out. Well, I'm hoping that you guys in the medical field will feel okay about me showing teeth and gums and all the internal parts of the oral cavity. So anyway, But we take measurements to, what we want to do is gather a baseline of information so that we know how their bite is, how their teeth are positioned, where their midlines are of upper and lower teeth, if their teeth are worn, how their bite comes together. We gather all this information so we have a baseline so we can see if things have changed, it will have changed in the future as we follow them. We check their periodontal condition, check for tooth mobility, we check for any lesions, we do an oral cancer screening. We'll check jaw range of motion, opening, closing, moving side to side, because this may impact whether or not they can tolerate an oral appliance. I've sent a number of patients to physical therapy for improving their jaw function before we start treatment. It's not a high percentage, it's a very small percentage, but these are the things we need to determine. We also need to know if their jaw deviates. As they move their jaw forward, does it shift to one side or the other? Because that will impact our ability to position an oral appliance. It doesn't keep us from treating them with an oral appliance, but it helps us in setting up the appliance in a way that will be comfortable for those people, for those patients. We do a complete TMJ evaluation and palpate the joints. We listen to the joints. We palpate muscles around the joint, and we inform the patient if we notice anything. We check neck size, and we do imaging to assess and make sure that the structures are healthy and get a sense about, give us some information about airway on imaging. Then we'll check the oropharyngeal tissues, the size of the tongue, the length of the soft palate, the size of the uvula, if there's crowding in the palatopharyngeal area. And this is important baseline information. And you can see, I know that all of you are doing this in your examination, looking at the size and shape of the uvula, and there's so much variability. The palatopharyngeal arches, the tonsils, and then we look at the tongue. And, you can look, if you look at size of tongue in this patient here, the top picture is pretty typical. The lower picture, there's infero-superiorly, it's a little, I would say moderately large, but look at the size of this tongue on the top picture. Do you see how it overlaps all the teeth? And so it's, some of us in the office call this the quarter pounder. I mean, it's huge laterally. And you look at the lower picture and the tongue is filling the mouth. So, the question sometimes comes up, well, will a mandibular advancement device help in these patients? And what we find is it's actually more effective it's more effective in opening the airway in these patients than a tongue retaining device. So when we assess the tongue, I basically use descriptors. I mean, is the tongue small, large, like eggs, small, medium, large, extra large, jumbo? But I also describe it as to whether it's large laterally, inferior, superiorly. And then we take a look at the length of the soft palate. It's fairly normal on the right side. You can see the lateral pharyngeal walls on the right picture. On the left side, it's looks more typical. On the right side, you can see a broad pharyngeal curtain laterally. Here you can see, in Minnesota, we call the uvula icicle shaped, but again, broad pharyngeal curtain. And you can see on the right side that the tonsils are kissing the uvula. So there is so much crowding in that palatopharyngeal area that's certainly an issue. We use the Mallampati classification. The problem is that so many of our patients are class 3 or class 4. It doesn't really give me as much information as I would like, except, so then I will put descriptors in my notes that the soft palate is long, that it has a broad pharyngeal curtain, it's moderate length. The uvula, I give descriptions, it's thick, it's thin, it's long, it's, those sorts of things, just so that I have a sense of what I'm looking at and documenting. Here's an important point that I don't think many physicians would be aware of, and that is that the shape and size of the dental arch is really important because it is the compartment within which the tongue sits. So you may look in the mouth and see a huge tongue, but the question is the compartment that is in small, so the tongue looks large, or is it that the tongue is larger in any event? So I'm constantly looking at the shape of the dental arch because we know the tongue has to come up into the mouth to stay out of the throat. And if there's not enough space in that dental arch for the tongue to come up and forward, then the throat's going to be crowded, which impacts breathing, swallowing, and speaking. So that's an important point I just wanted to mention. Then we do imaging, and cone beam CT is becoming a much bigger player in assessment. The challenge with cone beam CT right now is that we don't have any correlation studies to give us an idea of whether a cone beam CT done on an awake person sitting up or even lying down is correlated to apnea severity, and whether or not we can determine who will be a responder to oral appliance therapy based on the CBCT or cone beam CT data. So I am still using cephalometric x-rays, which are lateral head x-rays, which will show the throat and airway, but it's a 2D image of a 3D space. On the other hand, it gives me good information in looking at the angles and the size of the tissues from a lateral perspective. In addition, we do a panoramic x-ray, which is I think important to look at the underlying structures in the jaw, sinuses, and teeth. So we'll do a cephalometric and panoramic x-ray in the future. I'm sure once cone beam CT studies have been done to give more correlation with sleep apnea therapy, we'll probably shift to see cone beam. Once we've gathered all the information, we sit down with the patient and we do a consultation. And basically, we're going to, as you do in your consultations, we'll describe what's happening, what our findings are, lay out for them why they may be experiencing apnea and what some of the factors are that may be contributing to it. And then we talk about CPAP, and most of them have tried it. We'll talk about that. We'll talk about surgical options, and then we'll talk about oral appliance therapy. If they're interested in oral appliance therapy, we work with 10 different oral appliances in our office. So we customize the device to the patient's situation. And we are experienced in working with 10 different devices, so we can kind of customize therapy. And we'll give the patient a couple of options on what we think would work best in their situation, and then they decide if they want to move forward. If they do want to move forward, our office is using digital impressions of the teeth, and you can see on the top left picture, we use a wand that basically is a camera that goes around, and it gives us really accurate imaging of the teeth. You can see on the screen behind the patient, you can see the image of the upper arch there, and that's the kind of images we get. We used to do impressions with an impression material in a tray. We don't use that anymore very much. And then we'll take a measurement. On the right, you can see a device called a George gauge. And what we do with this is we take a measurement of where we want the appliance positioned, and then we scan it with the scanner, so we have a replica of how the jaw will be positioned in the appliance. We make sure the patient is comfortable in that position. Then we have the appliance fabricated at the dental lab. It's custom made. And the patient comes in. It takes about 3 to 4 weeks to custom make the device. We go through care and cleaning instructions. We make sure they can place the device and remove it, and that it's comfortable on their teeth. Then we teach them about adjusting the screw mechanism. So we have them make no adjustments to the appliance during the first week. They just get comfortable with the device and monitor their symptoms. After a week, if they're better but not better enough, in other words, their symptoms are still, they're better but they're not improved enough, then we will have them advance the jaw position with the screw mechanism or with the device, however, whether it's screws or straps, and they advance it 0.5 millimeter and monitor it for another week. And every week they can advance it slowly until they find that their symptoms are resolved. In addition, we give them a program like I showed you with an AM aligner to guide their jaw back into position in the morning. Takes somewhere between 15 and 20 minutes while they're getting ready for work or before breakfast. And patients do really well with that. Then we'll contact the patient in a week to check in and make sure, see how they're doing, and see if they have any questions. We update their progress. And if they have any fine-tuning adjustments on the appliance that are needed, we get them in and do that. Then we see them at 4 to 6 weeks. Again, we update how they're doing compared to their pre-treatment symptoms. And we go through the examination again to compare where they're at now with where they were prior to treatment and make sure that everything is remaining stable. Once the patient is feeling better and they feel like their symptoms are resolved, we may do some home testing to see if we're in the ballpark with managing their apnea. But then we refer them back to the sleep medicine provider, usually once they have relief of symptoms. And if their home sleep test looks like there's definite improvement, or if patients are not improving, if we work with them for, let's say, 3-4 months and they're improving but not enough, then we send them back to talk about combination therapy or other alternatives. Once we send them back, usually there's testing done. A lot of it's done now, home sleep testing. But we did, like I said, we did a study in 2000, published in 2009 in the Journal of Clinical Sleep Medicine. We fax over orders to the sleep center. Patient will come in the night of the test. They'll wear their appliance. They've already advanced it to where they think it's working. 40% of the time, no adjustment is needed during the sleep study. 60% of the patients needed to advance it further to get their apnea down to normal range. And what we tell the technologists is, if they still have apnea of significance, like an AHI greater than 10 or an RDI greater than 15, go in and the sleep physician, sleep provider will make the determination. But if they want an AHI below 5 as the marker, that's fine. If they want an AHI below 10, it depends on where the patient starts at as far as the severity of their apnea in most cases. But they tell the patient, they wake up the patient, tell them to advance their appliance 1 millimeter and then go back to sleep. And they do that periodically during the night until the apnea is resolved. If it looks like their apnea won't be resolved, then we generally put them on CPAP with the appliance or CPAP alone. After we've determined that the appliance is effective, the patient's placed on 6-month follow-up, as I mentioned, and then yearly thereafter. So what are the predictors of success with a mandibular advancement device? In other words, if you have a patient who comes in, and how do we talk to patients in our office as well about success? What we want to do is we want to match the features of the appliance with the characteristics of the patients. And we look at their pathophysiologic traits. And the other piece that has been found in studies to make a difference is the expertise of the dentist and how much experience they have in working with oral appliances for patients. That will impact success as well. But there are literally a few dozen appliances that are FDA approved. And so, as I mentioned, we've narrowed it down to about 10 appliances. And they have different features. They got different types of screw mechanisms. You can see on my cursor, this screw mechanism is in the anterior of the device, which is helpful in some respects, but challenging in others. This device has straps on it instead of screws. This device has screws on it, but it's a screw arm. The one below it here has an expansion screw, which is smaller and embedded in plastic. This device has no screws. It's got wings on the top and bottom that hold the jaw forward. This has elastic straps on it, if you're following my cursor. Then we look at the characteristics of the patient. If you look at the upper left, you can see how worn those teeth are. This is somebody who's a heavy bruxer. The one in the middle here on the top is a small dental arch. And so these patients potentially may be gaggers. You can see the gagger on the far right. Some people have trouble breathing through their nose. Others have a small mouth opening, so we want to use a smaller appliance. Some patients have different relationship of the upper and lower jaw. We have people with missing teeth that we can place appliances on. It's a little harder in patients with full upper and lower dentures. But if you look at the far lower left here, this patient has no teeth on the upper, but they have teeth on the lower, and we have been able to successfully manage these patients with a mandibular advancement device if you use the right appliance. And that's why I say you have to match the device to the patient's situation. Then you have patients like the lower right here who have challenges with dexterity. So using a simpler device that doesn't require a lot of dexterity would be appropriate. So those are just some of the factors as we're thinking about how we can increase success. In addition, there are some positive predictors. Women tend to do a little better than men. Younger people tend to do better than older people. Thinner people tend to do better than obese. Smaller neck circumference tend to do better. Lower AHI, as we already talked about, tend to do better than high AHIs. Primary collapse in the oropharyngeal area, and that's sometimes hard to determine. And there's a study done, there were two studies done. One said that a CPAP pressure less than 10.5 had a higher probability of success with oral appliances. And another study said a CPAP pressure less than 13 had a higher probability of success. So these are some of the predictors. And again, the data is, I would call them trends. I wouldn't call them cause and effect or strong predictors. What I've seen in my practice and what I think you will find in talking to dentists that do this a lot is it's much harder to maintain an airway with an oral appliance alone in somebody who's morbidly obese, somebody who's older, just because the tissues don't respond quite the same, although I have quite a number of patients who are in their late 70s and 80s, and they're doing well with the appliance. But still, I would say that's a trend. And somebody who has severe apnea with significant desaturations. I've treated patients with an AHI of 102 and got them down to 2 or 3. But it was patients who didn't desaturate dramatically. They had a lot of events, but they were mild events. And so when I see somebody who's got severe apnea like that, and they desaturate significantly, I think we're going to have much less success with oral appliances. So I wanted to kind of give you a sense about where it works best and where it may not work as well. Combination therapy is becoming much more common. Combining oral appliances with positional therapy can be extremely helpful. This is if we find that the appliance alone is not effective enough. Combination of oral appliances with CPAP we're doing a lot of now. And so these are patients that are struggling with CPAP pressure. When we place the appliance, we are able to turn down the pressure and maintain the airway still maintain the airway effectively. And it's like CPR. When you move the jaw forward, it stabilizes the airway. And because of that, as it relates to CPAP, it can allow you to reduce CPAP pressure. We've done it in combination with upper airway surgery and Inspire, and it has been additive. It's been helpful. And palatal surgery as well. So combination therapy is happening a lot more, and I think it's something to keep an eye on if patients are really struggling with CPAP and they have severe apnea. All right, the question always comes up, well, what about insurance coverage? So, I mean, the fee range for these appliances, and it depends on what area of the country you're in, but an $800 appliance is not going to be a long-lasting appliance. It's going to be a much simpler device, and it may have a lot less success. But that is the $800 to $3,000 is typically the range of the appliances, depending on the patient complexity. Most insurance carriers cover oral appliance therapy somewhere between 50 and 100%. Depending on if the dentist is in network. And again, this is not dental insurance, it is health insurance. And in our office, we check on coverage before the patient comes in, and we go through that with the patient when they're in the office so they know what their out-of-pocket expense is. And I think a dental sleep medicine provider should be able to do that to help the patient make a decision. I think the takeaway message is that collaboration with a dental sleep medicine provider is really, I think, vital to creating a comprehensive team for managing patients with sleep apnea. These devices do work, but they need to be customized in the right patients, just like you do in customizing therapy for your patients with whatever sleep issue it is, whether it's sleep apnea or insomnia, restless legs, whatever. So, but I think it would be really helpful for all of you to start to have conversations with dental sleep medicine providers in your area. And the best way to find dental sleep medicine providers in your area is the American Academy of Dental Sleep Medicine. AADSM.org is the website, and they have a Find a Dentist log. I strongly urge you to work with dentists who are board certified, who are diplomats of the American Board of Dental Sleep Medicine, because they have gone through the training and testing and have certification to do this, and so they'll likely have more experience. Working with a qualified dentist is somebody who's had at least 25 hours of continuing education in dental sleep medicine, so they may not have as much experience, but at least they've started on the path. So that's something to encourage you to do as well.
Okay, so one of the questions that I get frequently asked in the clinic when I bring up a topic of oral appliances for my patients is whether it has any cosmetic effects or not. Especially in, female, it's, major concern. What are your thoughts on that?
I have not seen that. I have had, so it's an interesting question. One of the things I know about oral appliances is that once you place one, people's awareness of their teeth, bite, lips increases because this is where the device is. So I will have we take photos of the patients before, after they get their appliance, immediately on the day they get their appliance. And so there's no data showing any change in aesthetics. If their bite starts to change, the amount of change is not dramatic enough. Have I ever seen it? Yes. Is there a high probability? No. It is, I would say, way less than 1%. So everything we do in medicine is based on probability. And so when you weigh and each person has to decide, but when you weigh the consequences of sleep apnea versus a low probability of changes in aesthetics, the patient's the only one who can decide, but I think the probabilities are very low. And that is rarely, if ever, talked about at scientific meetings because we're just not seeing it. We do see changes in bites. Typically, that's not noticeable to others. So it's a fair question, and I certainly hear that periodically from patients. And I'm not saying it can't happen, but the probability is really low. Does that answer your question? Does that make sense?
Yeah. Thank you. Yeah.
You're welcome.
It does. Thanks.
Yep. Anybody else? Other questions?
Yeah, I have one.
Please.
So you mentioned that combination therapy with a CPAP device was becoming more common. Is that to decrease the pressures required for CPAP to be effective?
Yeah, I think that would be the primary reason. And there have been there's been a lot more investigation of this. There have not been any randomized controlled trials using combination therapy that I'm aware of yet, although I think they're starting or are in process. But there have been a lot of clinical studies done of patients who couldn't tolerate CPAP pressures, and they've seen a definite improvement, and they're able to tolerate their CPAP if they wear it with an oral appliance. So we're seeing it a lot more now, and it's in patients with pretty severe apnea where they really need treatment, and surgery, they may not be interested in surgery. And so when we combine therapy, it has really made a difference. So I think it's definitely worth looking at in your, in trying to determine what the possible treatment options might be if you run into challenges with CPAP alone.
Okay, thank you.
Thank you for the question.
We do have a question in the chat.
Yes, please.
Will you use OAT in a patient who already has TMJ dysfunction?
So that's a great question. So OAT is oral appliance therapy. TMJ dysfunction, I think, needs to be defined. And so in patients who have clicking noises in their jaw and so on, I would say I do it every day and effectively without much consequence at all. I'm not saying it couldn't irritate the joints. TMJ just stands for temporal mandibular joint or jaw joint. The clicking in the jaw indicates that the disc in the joint is slightly out of position. 1 out of 3 people has that situation. Most people do not have symptoms around it. It's just there, and they chew and they do things and they function quite well. In those patients, we treat them with the mandibular advancement device and they do well. Some actually improve or they don't notice as much noise. In patients who have functional problems, in other words, restricted movement of their jaw or difficulty chewing because of a TMJ problem, I would absolutely treat the jaw problem first, working with physical therapy and maybe a different type of appliance to stabilize things. If they have pain that is occurring, is present currently, then I would manage that first. Pain in their jaw or with jaw function, I would definitely manage that first. But most of the people who have TMJ symptoms, they're mild and they tend to burn out over time as far as a functional problem or difficulty in their life. We hear most about people who have, pain in their jaw, and I would manage that first before starting this. But once it's managed and more stable, we do really well in working with mandibular advancement devices. Mandibular advancement devices can actually be helpful in managing jaw pain because it takes the load off the joint and it lengthens muscles so that there's less muscle tension. But I would prefer to manage the jaw pain first because it gets complicated otherwise if we're not able to manage the pain and they have a mandibular advancement device. So that's a great question. It's a really common question. Did I answer it? If you have a follow-up on that, I'm happy to weigh in. So please. I think that the bottom line is that we treat people with joint problems frequently. We just would prefer, if they have a current problem that's bothering them, that we manage that first. That's the summary.
Dr. Gupta said, yes, you answered the question. Thank you.
Okay, thank you for the question.
We have time for one more question. We're a little past the hour, but if anyone has one more question, we can take it. Okay. Thank you so much, Dr. Parker.
Thank you all. It was a pleasure to be here with you. Thank you.
And thank you to all who attended. We appreciate you attending these, and we look forward to having you join us next month as well. Thank you so much.
Have a good day, everybody.